let's go ahead and finish up with chapter 25, part 2. So where we left off, we were talking about brush border enzymes. So let's talk about some of the glands you find within the small intestines. There's a couple of important ones. So for instance, there's in the crypts of Leprechaun, you're going to find different types of cells within those different regions. So one cell type would be your goblet cells. Remember, your small intestines, you want them to be, want a lot of secretion of mucus in those areas because you're receiving food from the stomach. Remember, the stomach pH level can be pretty acidic, so it can get down to about 2 in terms of its pH. And so you want to be able to protect the the mucous membranes from that low pH. So you're going to have a lot of mucus-producing cells. Then you're also going to have a couple of these other hormones that get released. So these are enteroendocrine type compounds that get released. So cholecystokinin. We're going to talk about that a little bit later when we get into the gallbladder. Cholecystokinin basically gets released within the duodenum, and it helps to stimulate gallbladder contractions. So if you eat like a nice big fatty meal, you're going to want to release as much bile as possible because bile is going to act as an emulsifying agent to help entrap little tiny lipid molecules so that those could eventually become absorbed in your lacteals. Secretin, we talked about that very briefly, but we'll get into that in more detail later. But secretin is going to help to allow for pancreatic juices to get released. So it allows for the further secretion of pancreatic juices. Those would be your exocrine type compounds. So amylase, lipase, protease, all of those are going to fall within that category. And then we're going to talk about glucose-dependent insulinotropic peptide. It's also known as gastric inhibitory peptide, which we're going to talk about a little bit later. But effectively what happens with GIP is that it's going to allow for insulin release. So it's going to help to reduce gut motility. It's going to allow for now secretion of insulin so that you can absorb the sugars that are now being circulated within your circulatory system. So let's talk about those brush border enzymes now. So these brush border enzymes, as we closed on last time, those do not get secreted. Those are going to remain within the mucosal membranes, but they're going to be really important for the breakdown of several different sugar types. Okay, so you have these disaccharides like maltose, lactose, and sucrose, and those are going to be broken down by these brush border enzymes. So each of those are going to correspond with their own individual disaccharides. So lactase is one enzyme, for instance, corresponds to lactose breakdown. What does lactose break down into? One glucose molecule and one galactose molecule. Okay, so those are going to be the monosaccharides that are as a result. Maltase is going to break down maltose. Maltose is going to turn into 2 glucose monosaccharides. And then sucrase is going to break down sucrose, which is going to result in 1 glucose and 1 fructose monosaccharide. And then the other brush border enzyme would be the enteropeptidase. So you have the conversion of trypsinogen into trypsin. And basically what trypsin allows you to do is to break down different types of proteins. So they're kind of a proteolytic type enzyme. So you can break down, you can convert elastase, will help to break elastic type proteins, chymotrypsin. So don't commit these to memory. It's not super high yield, but just know that trypsin is going to allow for proteolytic enzymes to be converted into their active form. And then proteases effectively just break down different types of proteins. Okay, so not super high yield, but it's good to know. Make sure you know what these are going to be associated with those. So sucrase, maltase, and lactase. Those are going to be extremely important. Let's see, within the intestinal crypt, you're going to get the release of those those hormones, as I mentioned already. Gastrin. What does gastrin do? It increases gastric motility, right? And it also helps promote the release of hydrochloric acid. Cholecystokinin, or CCK, is going to allow for increased secretion of bile, so gallbladder contractions. And then secretin is going to allow for all those pancreatic fluids to get released. And then in terms of the mucus that's being secreted, the mucus that's being secreted to help buffer the pH is going to be really high in bicarbonate. Bicarbonate is an alkaline compound, so when bicarbonate is in the presence of hydrochloric acid, you start to be able to neutralize that pH. So it's going to help to reduce the acidity and increase the alkalinity of the chyme as it travels through the small intestines. Okay, so here's the breakdown of those different disaccharides as I was mentioning. As amylase starts breaking down carbohydrates, remember carbohydrates are going to be large, complex type molecules. As they're getting broken down, they get broken down into disaccharides. Those disaccharides aren't really going to be affected by amylase anymore. Amylase only really starts breaking those large carbohydrates down into their smaller disaccharide, but not down to the individual monomers. In order to get down to the monomer sugars, then you're going to need all these different enzymes. So maltase, sucrase, lactase, those are the main ones. Make sure you know what each of these turn into. So maltose, I think of like malt liquor, and in order to make alcohol, you need sugar. So I think of maltose as turning into 2 glucose monomers. Sucrose, that's basically table sugar. Sucrose is going to turn into 1 glucose and 1 fructose. But notice the commonality here, glucose, glucose, glucose. Lactose is also going to turn into 1 glucose monomer, but it's also going to turn into a galactose. Okay, so make sure you know which of these sugars are associated with each of the disaccharides. So each of the monosaccharides, know where they come from, okay? This is a really good chart that kind of gives you a breakdown of everything that's going on at the level of the duodenum. And so once chyme starts entering into the duodenum, that's where you get the release of all these different compounds. So you get the release of secretin. What does secretin do? Mostly it's going to help to start releasing different types of digestive enzymes from the pancreas. It's also going to have a little bit of effect on bile secretion. So secretin, just think about secretin as increasing different types of secretions into the GI tract. Cholecystokinin, or CCK, that's also going to help stimulate the secretion of different types of pancreatic fluids. But the most important thing with CCK is going to be this, gallbladder contractions. Okay, gallbladder contractions are going to allow for the release of bile, which is going to be allowing for the digestion of lipids. Okay, that's the main thing, because it's an emulsifying agent. So in other words, as an emulsifier, it surrounds the lipid molecule so that the lipid can actually get absorbed. Otherwise, the lipids are going to be free floating. They're not going to be able to absorb into the small intestine. They have to be emulsified first. And then GIP, that's the gastric inhibitory peptide, also known as glucose-dependent insulinotropic peptide. But just think of GIP as being something that reduces gastric motility. Because GIP, once it starts getting released, then that means that you've already eaten. You don't need to eat any more food, so you're going to start decreasing your gastric motility. In other words, it's going to block those G cells from doing their thing. Remember, G cells release gastrin. Right? Gastrin allows for increased gastric motility as well as the release of hydrochloric acid. At that point, you don't need to do that anymore. So that's what GIP starts doing. It starts reducing the amount of gastric motility, but it's also going to allow for the increased release of insulin. Okay, so insulin now, after you ate, you're going to start absorbing those different sugars that you're breaking down. You're going to have a glucose spike in your blood, right? So you're going to have insulin release as a consequence, so you can absorb all the glucose that you just consumed and absorbed. So here's just a big schematic breakdown of everything that's going on. So you got that whole cephalic phase where you're thinking of a nice, delicious, for example, steak, right? And then all of a sudden, just the thought of it, or even just the smells, all that sensory input. When you have the sensory input, now your stomach is going to start getting primed to receive the meal. Then you do indeed eat the meal. Then you're going to have the gastric phase. Eventually you have the intestinal phase. And all the different stuff that's going on here, i.e. the release of gastrin from G cells, which is allowing for the release of hydrochloric acid from parietal cells. And then you get the conversion of pepsinogen into pepsin by the presence of hydrochloric acid. Then you can start digesting proteins with pepsin, and then so on and so forth. Once the food enters into the small intestines, then you get the brush border enzymes being activated, CCK being released, and all that. So this is a good schematic for you to go over. It kind of sums everything up that we talked about already. Let's watch a little video of peristalsis. I already showed you a couple of videos already, but here's another video. It's kind of interesting. So you see like those peristaltic contractions. See a little bit of segmentation taking place over here as well. Okay, you get the picture. So in terms of beginning to end, as soon as like food enters into your duodenum until it's excreted as solid waste, it's going to take about 5 hours total for that whole process to take place. Remember, food, once it enters into the stomach, it can hang out in there for about 1 to 2 hours while it's getting like mechanically and chemically digested. Then once food gets into the duodenum, you're looking at 5 hours for it to pass throughout the course of the small intestines, and then eventually out into the large intestines. And then in terms of the small intestines, make sure you know the order. It goes duodenum, jejunum, and then ileum until it makes its way into the large intestines. So let's go ahead and do a quizzes. And then we'll continue on to chapter 25, part 3. Okay, there we go. Okay, so I counted 50 people. Okay, if you weren't able to log in, just give us your names afterwards. Let's go ahead and start. All right, so make sure, no, definitely not Crohn's disease. Make sure that you know what intrinsic factor does. Intrinsic factor is going to be released by what type of cells? Do you guys remember? Parietal cells, good. Parietal cells release hydrochloric acid and they release intrinsic factor. Intrinsic factor allows the absorption of vitamin B12. Where in the GI tract does vitamin B12 get absorbed? Huh? Ileum? Yes, the ileum. So if you weren't able to produce intrinsic factor, you wouldn't be able to absorb vitamin B12. As a consequence, you would get anemia. Do you guys remember the specific type of anemia? Pernicious anemia, good. So you get like megaloblastic, they have really large red blood cells, hyperchromic because you have like reduced pigmentation of those red blood cells. So you get pernicious anemia as a consequence. Crohn's disease is a little bit different. That's going to be inflammatory bowel disease. What's up? Huh? Yeah, they're embedded within your PowerPoint presentations. You guys are able to access them, right, on your own? Okay, good. Good. Most of you guys got this correct, which is awesome. When you break down proteins, you got pepsin. Pepsin is going to be the active form of pepsinogen. Pepsinogen requires what to convert to pepsin? Hydrochloric acid. Good. Excellent. Good. Yeah, the majority of everything being absorbed is going to take place within the small intestine. A little bit in the stomach, a little bit in the large intestine too. Good. Activated by the presence of hydrochloric acid within the stomach. Pepsinogen into pepsin. Good. Parietal cells. Chief cells secrete what? Pepsinogen and lipase. Good. Pepsinogen and gastric lipase. Awesome. All right, let's move on. A couple more. Awesome. Most of you guys got that right. It's a GIP. Gets released after you're done eating, basically, and it's going to basically say don't eat anymore. It's going to reduce gastric motility by basically blocking those G cells to reduce gastrin secretions. It's going to increase insulin as a consequence. All right, 2 more, 3 more. All right, good. Pretty straightforward. Nothing really too crazy. What does lactose turn into? Or the two Monosaccharides? Galactose. Yeah, glucose, galactose. Good. Awesome. Let's see the other ones. What about maltose? Glucose and glucose. Two glucoses. What about sucrose? Good. Awesome. Good job. Okay. I hope everybody got this one right. Good. Most of you guys got that right. So yeah, lactose, glucose, galactose. Okay. Last one before we move on. Good. Gastric inhibitory peptide or glucose dependent. What was it? I forgot the term for it. But GIP. That's what's going to be increasing insulin release. All right. So make sure you know GIP. Secretin might have a little bit of an involvement in releasing insulin from the pancreas, but when you're thinking GIP is going to have a more outweighed effect on the pancreas when it comes to insulin. All right, cool. So move on. Okay, so let's go into chapter 25, part 3. Anyways, I really like Greek mythology. Prometheus, interesting dude. He was punished for allowing humans to wield fire. And according to Greek mythology, he was punished by being tied to a mountain where an eagle would come down, eat his liver, and then fly away. Overnight, his liver would regenerate. The eagle would come back the next day, eat his liver, and that was his punishment for all of eternity. The reason why that's interesting is because the liver can regenerate 90% of all of its tissues. If you removed 90% of your liver, it would completely regenerate on its own. So liver is really interesting because of that. So we're going to talk more about liver and what the liver does, lots of different functions. We'll talk about it momentarily. But first, let's talk about the pancreas. So this is what the pancreas looks like. It's got a couple different sections. It's got the tail, it's got the body, it's got the head. We've already talked about the pancreas before when we were discussing hormones like insulin and glucagon. So we're not going to go into too much detail about that. But know that you have both exocrine and endocrine function. Endocrine function, that's going to be in the islets of Langerhans, right? That's going to be your alpha cells, beta cells. Which one secretes what? Alpha cells secrete what? Do you guys remember? Glucagon. Beta cells, insulin. Awesome. So that's going to be these guys over here. And then you have your exocrine cells, and those are going to be referred to as the Acini cells. And so those are going to be releasing all sorts of different things. So like amylase, lipase, protease, etc. In terms of the ducts, so the major duct is going to be the major duodenal papilla. You also have the minor duodenal papilla up here. But the majority of bile and pancreatic enzymes are going to be secreted into the major duodenal papilla. That's also where you see the merging of the bile duct as well. So you get both bile and pancreatic enzymes being secreted into the duodenum via this duct. So I'm going to go into a little bit more detail about the different regions of that duct later. But so as I mentioned, hormones, you get insulin, glucagon, those are the major ones, and then you have exocrine function. You also get buffers, so like bicarbonate, for instance, is going to be something that helps to buffer the contents of your chyme, right? Because you have low pH coming from your stomach. Bicarbonate is going to help to elevate that pH level to make it more alkaline. And the main thing that the pancreas does is going to break down fats, carbs, and proteins. Fats, lipase, carbs, amylase, proteins through pancreatic protease. So let's talk about amylase real briefly. It's going to turn those polysaccharides into disaccharides. Where do you see those disaccharides getting broken down into monosaccharides? Starts with a B. The brush border. Yeah, good. So the brush border enzymes are going to help to further break down those disaccharides into those monosaccharides. So sucrase, lactase, and God, what's the other one? My brain just gave up on me for a second. Sucrase, lactase, and So sucrase, lactase, and what was the other one? Sorry, I'm lactase. Maltase. My God, sorry, that's so embarrassing. Brain fart. It's been a long week. All right, then pancreatic lipase, that's going to be what breaks down all of your lipids, right? So it's going to turn triglycerides down into all those individual components that make up a triglyceride. So you don't need to commit this to memory, but it's going to turn into a couple different fatty acids as well as a monoglyceride. That's what makes up a triglyceride. Then proteases and your proteolytic enzymes breaks down proteins. Nothing really too crazy. So we talked about peptidases that help to break down, for instance, like elastic type tissue with elastase. So you don't have to commit these ones specifically to memory, but just know that proteases are going to help to break down proteins. And then, of course, the brush border enzymes, that's what helps to break down enteropeptidases at the brush border enzymes is what helps to break down some of these proteins as well through the conversion of trypsinogen into trypsin. And then nucleases, whenever you consume anything that has like proteins in it, you're also going to be consuming things like DNA, right? So nucleases help to break down any of those nucleic acids like DNA as well as RNA. Okay, so that's going to be the purpose of nucleases. And then here is an overall summary of what's going on in terms of carbohydrate, protein, and lipid breakdown. You see everything taking place all the way from oral cavity leading down to your intestinal mucosa. So this is a really good chart. It shows how each of those are going to be broken down, including where they're actually going to enter in once they get broken down. So for instance, your lipids are eventually going to make their way down to the lacteals, right? And so they're going to turn into chylomicrons at the level of the lacteals. So here's a good overview of what's happening with breakdown of those different components. So let's talk about the liver. The liver does many things. The liver is a very important organ. It's going to break down things like toxins. It's going to also help to create things like different types of amino acids. Albumin, for example, is going to be an important protein that's produced by the liver. So if you're like this dude over here and you drink too much, eventually you might become cirrhotic. If you become cirrhotic, you're not going to properly be able to produce things like albumin. As a consequence, you won't be able to maintain your oncotic pressures. You'll start becoming a little bit edemic, right? You'll start getting edema, swelling as a consequence. So the liver also is important in storage of glycogen, right? Glycogen is a really important multi-branch storage molecule, stored in the liver, also stored in skeletal muscle. So lots of different functions. The liver, because it serves all these different functions, it's going to receive lots of blood. So we talk about the portal system in the liver, so the hepatic portal system, where you have all these different blood vessels in the venous system leading to the liver, so that the liver can sort of act as a filtration system. The liver is also going to help filter things like medications, drugs. A lot of drugs that are orally consumed are going to undergo a first pass effect. So they're going to eventually make their way to the liver, and they're already going to get metabolized by the liver before they actually have their function. So whenever you take a medication, you got to take into consideration the first pass effect. There's ways to bypass that first pass effect. You could do insufflation, suppositories can also bypass that. Intravenous administration of certain medications can also help bypass that. But just know that the liver is going to be involved in the metabolism of drugs. You're going to get the production of albumins as well as globulins, other things, removal of toxins, and then for what we've been talking about now, the production of bile. That's going to help to absorb lipids, right? So bile is going to act as an emulsifier, traps those lipids up so that they can be absorbed into the small intestine. And then I wanted to include Brian Johnson here again, the Liver King, who he's not ripped because of all the raw liver he eats, it's because of all the anabolic steroids he takes. So don't eat raw meat daily, okay? There's lots of parasites in meat. That's why we cook our food, so you can kill off any sort of potential pathogens in there. So anyways, to each their own, I guess. So these are the different structures in the liver. I'm not going to go into full detail about this. This is, you can study this in your anatomy lab instead. But know that this is what where the vessels come through. They get filtered out into different bile ducts. So yeah, don't concern yourself too much with all the details here on the structures of the liver. One thing, though, that you should take into consideration is the hepatic portal system. Because the hepatic portal system, check it out over here. This is like within the mesenteric vessels. You're having all these different venous blood vessels coming from the GI tract, right? And it's bringing blood directly into the liver. Whatever you're going to eat that gets absorbed in your GI tract is eventually going to make its way through the liver, right? So that's one of the first portals of entry. And so anything that you eat is basically going to get filtered into the liver through different vessels. So you have the hepatic portal vein, you have the superior mesenteric vein, and then you have also the splenic vein coming from the spleen. And then these are all the different things that the liver does. So gluconeogenesis is going to be really important in terms of like metabolism of glucose and creating new glucose molecules. Lipid metabolism is going to be really important. Amino acid metabolism is going to be really important. Also, vitamin storage. So the liver is going to be responsible for your fat-soluble vitamins. Fat-soluble, just think ADDIC, vitamin A, D, E, and K are all your fat lipid-soluble vitamins. Those are going to be stored in the liver, as well as vitamin B12. The first pass effect, that's drug metabolism. Okay, that's going to happen within the liver. It also happens in other target organs as well, but it's mostly going to be associated with the liver, where you have the overall active ingredients within drugs basically falling in their quantity because a lot of it's being metabolized within the liver. And then production of different important proteins like albumin, which we mentioned, clotting factors. If a person has liver failure, they're going to start having nosebleeds. They're going to start having bleeds in places where they shouldn't, right? So your clotting factors are actually produced by your liver. So if you have cirrhosis for whatever reason, if you have liver failure, then you're going to also not be able to produce your proper amount of clotting factors, so you're going to be bleeding out a lot easier. And then, of course, the synthesis of bile is going to be one of the major effects of the liver. So here was just a side note that I want to include in here with regard to the first pass effect with drugs. Key thing to keep in mind here is if you wanted to bypass this first pass effect, these are the ways that you could do it. Insufflation. Does anybody know what insufflation means? Up the nose. Okay, so that would be like snorting something. So you can insufflate a lot of different types of meds. That'd be one way to bypass it. Suppositories, you guys know what suppositories are, right? Okay, yeah, so it's going to be within the rectum. Intravenous, intramuscular, you can also inhale aerosols. That could also bypass that first pass effect. Sublingual. So sublingual is an interesting thing. Remember we talked about angina, patients that have like chest pain because of like vasospasms or vasoconstrictions of their coronary vessels. They get chest pain because of that. They get ischemic type pains in their heart. They can take sublingual nitroglyceride tablets. Those nitroglyceride tablets will go directly to the heart. Okay, so they'll go directly to the heart. They'll completely bypass the liver. So whenever a patient has angina, if they do a sublingual nitroglycerin tablet, they're able to address the angina pretty rapidly because it goes directly to the target organs. And then this is just a side note on glycogen storage. So this is what you'd be focusing on right over here. Okay, So you'd be turning glucose into glycogen. Glycogen thereby gets stored not only in the liver, but it's also going to get stored in skeletal muscle. So it's going to be a really important molecule that allows you to dip into energy reserves whenever you need to increase your metabolic demands. And then a side note on hepatocyte regeneration. So it's really interesting because we already talked about what's going on here with Prometheus, but these are not due to stem cells. Okay, so hepatocyte regeneration is actually due to the cells themselves. So there's a couple different zones, but within zone 2 over here, right in the middle, those are the bulk of the cells that actually are able to reproduce themselves so they can regenerate the rest of the liver. So super cool. So you can literally remove up to 90% of the liver and it will regenerate. However, the liver is not, shall we say, immortal, right? So it can, once it gets to a certain amount of damage, then it becomes irreversible at a certain point. So let's talk about different types of liver damage. So healthy liver, and then all the different stages until you get to the very end, which would be ultimately hepatocellular carcinoma. So let's take an example of a patient with hepatitis C virus. Okay, so hep C virus eventually becomes chronic, right? It's there's no cure for it. Some literature says there's cures. I've spoken to like gastroenterologists that say there's cures, but those drugs are extremely expensive, and as far as I know, insurance doesn't cover them. So for practical purposes, there's not really much in terms of a cure for hep C. So if you get hep C, eventually these are all the progressions your liver is going to undergo throughout the years of chronic inflammation. First stage is going to be steatosis, where it starts to get into like fatty liver disease. So steatosis is another fancy word for fatty liver disease. The first and only autopsy I ever participated in was a really morbidly obese person. When the pathologist went in there and was harvesting like samples of organs and tissues, when she removed a portion of the liver, you could literally look at the liver and you could see all the little fat globules within the liver. That's fatty liver disease, also referred to as steatosis. A person with steatosis, one thing that they might complain of in terms of symptoms is a foul floating stool that hangs out at the top of the water in the toilet. Because of all that fat, it starts to float on top. And so if they have a greasy, tarry stool, that's going to be associated with steatorrhea, which is associated with steatosis. So that's the first stages of liver damage. It is reversible, though. If you remove the insult that's causing steatosis, say, for instance, alcoholism or drug abuse of some sort, or perhaps maybe the patient had hepatitis A virus, which is an acute damage to the liver, that will eventually resort back to its healthy state. Then fibrosis, that's going to be as the steatosis continues on, you start getting these fibrotic tissues start building up, and that is also going to be reversible too if you remove the insult. But if it's like a hepatitis C type scenario where it's a chronic inflammation, it's not going to reverse, then eventually you develop cirrhosis. And this is what cirrhosis looks like. You get all these little fibrotic scar tissues that build up. Basically, it interferes with the ability for the liver to properly function. And once you get cirrhosis, that's it. It's irreversible. You can't go back. The only way that you can treat cirrhosis is what? You guys know? Liver transplant. Exactly. You get a liver transplant. That's the only thing that can really cure cirrhosis. So in other words, you're not really curing it. You're just, swapping out the liver for someone else's. And then something that's common with patients with cirrhosis, alcoholism, as well as hepatitis C, even hep B does this too. 20% of hepatitis B will eventually become chronic. You'll get hepatocellular carcinoma as a consequence. So that's chronic inflammation of the liver. I included all the different things that can result in inflammation of the liver. Viral infections, hep C, hep B. You can have even autoimmune diseases that can cause this. Toxins, alcohol is super common. Obesity. Obesity can cause chronic liver disease over time, right? Because you have like fat accumulation over time. That fat can really cause a lot of damage and harm to the liver. So these are some of the symptoms of liver damage. So one thing to keep in mind here is jaundice. Okay, so jaundice is effectively an accumulation of bilirubin within your blood. Jaundice, if you get too much bilirubin, you start turning yellow. So you might get sclera icterus, which is yellowing of the conjunctiva. Your skin just in general is going to look a lot more yellowish in pigment. Other things to keep in mind in terms of stool and urine. So we're going to talk about the different components that contribute to the colors of stool as well as urine. But like stercobilin, for instance, contributes to like the browning of stool. If you have liver damage, you're going to get clay-colored stool. You're also going to get really dark urine as a consequence. So a patient with hepatitis A, for example, Hep A patients, one thing that they have is they're going to have clay-colored stools, and they're probably going to have dark urine as well as a consequence. Edema. Remember we talked about those important proteins, like albumin, for example. If you can't produce albumin due to liver damage, you're eventually going to become edematous as a consequence. So, any questions on the liver and the pancreas? What's up? Yeah. So there's jaundice of neonates. There's also kernicterus, which is irreversible, and that causes brain damage. But jaundice of neonates, yeah, they put them underneath UV type light, and that's going to help to, I forget if it helps to turn it to conjugated bilirubin. I can't remember the mechanism off the top of my head, but that's one of the treatments they do. It's very common for neonates to have jaundice once they're born, but usually they recover from that. There is a condition, though, where it's liver damage and it results in kernicterus, and that's permanent. That person will have like permanent brain damage as a consequence. So it results in encephalitis. So that's beyond the scope of this class. You'll maybe learn about that later on in pathology. So let's talk about the gallbladder. So this is an image that I pulled over here. This is a CT scan. Notice these little things right here? Those are not supposed to be there. Those are called gallstones. So that's gallstones as a consequence of just an accumulation of bile that kind of sits there. It becomes calcified. And so gallstones generally have to be removed surgically. Sometimes gallstones can pass by themselves, but it can be a very painful process. So gallstones, not fun. It can result in cholecystitis, which is inflammation of the gallbladder. So what's going on at the gallbladder? The gallbladder is basically storing bile, right? Bile gets produced in the liver. It gets funneled down into the gallbladder, and now it's stored in the gallbladder for whenever you're ready to release it after consuming, especially a fatty meal. So let's see here. Yeah, so with pancreatic lipase, remember we talked about lipase as being what breaks down lipids. If you break down lipids, it's going to break them down, but it's not going to be readily absorbed. In order for you to actually be able to absorb any sort of lipids, you need bile, because bile is going to act as a emulsifying agent. So this is what's going on with emulsification. So you have the liver, that's what's producing bile. Once bile gets transferred down into the bile ducts, it's going to eventually siphon into the gallbladder, because you have like a backflow. It's going to create pressure that's going to push it into the gallbladder instead, because without the presence of cholecystokinin, these sphincters over here, the duodenal papilla, they're not going to open up. They're going to remain closed. Okay, so in other words, you get a backing up of bile, and all that extra bile gets stored into the gallbladder. But when you eat of a meal that's high in lipids, then you're going to get the release of cholecystokinin. When cholecystokinin gets released, you're going to get relaxation of those duodenal papilla. So those sphincters are going to open up, and then you're going to get contractions of the gallbladder. So now bile can get siphoned into the duodenum. And this is what's happening with bile. You get these massive drops of lipids. They're not going to be easily absorbed. And so bile basically allows for emulsification. When you think about emulsification, you're thinking about breaking down those lipids. If you guys ever like washed a dirty dish that was covered in oil in the sink, you put detergent on that, right? The detergent does the same thing. Detergent acts as an emulsifier. It helps to trap those little lipids, or those bigger lipids, into smaller pieces that can easily get washed away and flushed down the drain. Very, not very similar. It's the exact same process when it comes to bile. It's going to act as an emulsifying agent. When you get cholelithiasis, so whenever you hear lith, that means a stone. So like nephrolithiasis would be kidney stones. Cholelithiasis would be gallstones. Gallstones are basically just calcium. It's like cholesterol and calcium that just kind of builds up over time, hardens up, turns into stones, and they can get passed through the bile duct, but it's a very painful process. Generally speaking, it has to be removed surgically. The surgeries for a cholecystectomy, which is the removal of a gallbladder, usually isn't very invasive. I've helped on quite a few of those surgeries when I was doing my surgery rotations, and it's laparoscopic. They just make 3 incisions in the abdomen, and then they go in there with cameras. Once they actually like remove the gallbladder, they can put it in a little pouch. They pull it into like a little sleeve, and they're able to remove it that way. There was only one surgery that I participated in, and the doc that I was working with was like a dinosaur. I think he was probably like in his 80s or something. And so we started it laparoscopically. He wasn't able to reach the gallbladder, and so we had to convert. So when you say convert, that means now you have to actually go in there and cut open the abdomen. So instead of 3 little incisions, now the person had like a 6-inch wide incision across their abdomen. So I think it was probably because the doctor was old and didn't really. Sometimes people need to learn when it's the right time to retire. Anyways, one of the rudest mnemonics in medicine is fat, female, 40, fertile, and fair. These are going to be the risk factors for cholelithiasis. So obesity is a risk factor. For some reason, women get more cholelithiasis than men, so that's why female. 40 is going to be around the age range when people start developing this condition. And then fair, it's going to happen more to Caucasian patients than other demographics. And this is what they look like. They look like these little tiny kind of like dark brown, dark green stones. All right, so let's move on. Yeah, jaundice. If you had a gallstone trapped within the bile duct, you get you start getting bile kind of like congesting the liver. That could also result in jaundice as a consequence. What's up? What happens after you remove your gallbladder? The gallbladder is not 100% necessary. It's just storage for storage for bile. But you have to have diet modifications. If anybody gets a cholecystectomy and they get their gallbladder removed, they really have to avoid fatty foods. Because if you eat fatty foods, that's going to cause extreme indigestion, right? Diarrhea, because they're not able to absorb the lipids now. In other words, the lipids are going to go somewhere, right? They're not going to get absorbed. And so it causes severe gastric discomfort, gastric distress. So those patients really need to go on a strict diet after they get their gallbladder removed. So really good question. All right, so the reason why I included this is because there's different names for these different papillae and different sphincters and whatnot. So when I went to med school, we refer to this specifically as the ampulla of Vater and the sphincter of Oddi. There are so many there's a couple different names for these different sphincters, but I included this in here because it can be a little confusing. The sphincter of Oddi, that's going to be basically the overall sphincter over here. That's going to be the sphincter that includes both the pancreatic duct as well as the common bile duct. And then the ampulla of Vater, that's going to be effectively the sphincter of the ampulla. So different terms make it a little confusing, but if you hear sphincter of Oddi, ampulla of Vater, just think of the area by which bile as well as pancreatic fluids will start entering into the duodenum. Okay, that's the long story short for this. I went down a rabbit hole trying to find all the different terms for these exact regions, but minutia, don't concern yourself with that. It's low yield. I'm not going to test you on it. Okay, so let's start talking about bicarbonate and other things that are going to be released as a consequence of secretin. So secretin is going to be released by S cells, and secretin effectively allows for basically the pancreas to start doing its job. And so this is going to be taking place at the level of the duodenum. Once food or chyme starts entering into the duodenum, then secretin starts getting released. Secretin is going to help to neutralize the pH as well of the chyme entering into the small intestines. Other things that's going to happen in the duodenum, we kind of already talked about it a little bit, but cholecystokinin, right? Cholecystokinin is going to help to contract the gallbladder. That's going to be one of the major functions of cholecystokinin. So in other words, as fats and lipids start entering into the duodenum, then you get the secretion of cholecystokinin. You can also get a little bit of release as a consequence of proteins in the duodenum as well. And then in terms of fats, I just added this in here just so, because there's a lot of talk about trans fats versus cis fats, unsaturated fats. When you talk about unsaturated fats, there's going to be more of a kink in the actual lipid itself, and so it's going to be more fluid at room temperature. If something is fluid at room temperature, generally speaking, it's going to be a little bit more of a healthier fat versus things that are going to be more solid at room temperature. If you have these trans orientations where it basically forms a long, thin line of lipids, then those are going to be getting more into the realm of like unhealthy fats. Those are fats that are going to be more solid at room temperature. They're going to get trapped into, like vessels. They're going to cause like plaque formations, things like that. So here's the summary of what's going on with lipids, cholecystokinin release, and then the contraction of the gallbladder, as well as the relaxation of those different sphincters to allow bile to be able to get released into the duodenum. Cool. So let's talk about GIP. So GIP is going to be glucose-dependent insulinotropic peptide, or also known as gastric inhibitory peptide. Just think about the I. Think about it as being inhibitory to gastric secretions, and then also think about insulin, right? So you're increasing insulin as a result. So these are all the things that happen with increased GIP, but mostly focus on pancreas over here. So you have increased insulin secretion as a consequence of GIP increase. Okay, when GIP gets released, you're thinking the person just ate. Now they're going to start breaking down those sugars, absorbing glucose into their bloodstream, and they're going to require insulin as a consequence. So know that GIP reduces gastric motility, increases insulin secretion, and even production. Gastrin. Remember we found G cells within the stomach. You also have G cells within the duodenum too. With gastrin release, remember that gastrin is going to increase gastric motility, and it's also going to help stimulate acid production, right? It's going to help stimulate those parietal cells from releasing hydrochloric acid. So here's a breakdown of all those different compounds. We already saw this graph in the last section of chapter 25. But just to reiterate, food, once it gets into the stomach, you get gastrin release from the G cells. You also get increased hydrochloric acid productions from your parietal cells. Once it gets into the duodenum, then you get cholecystokinin as well as secretin release. That's all going to help to release bicarb to help neutralize the chyme. It's also going to help release amylase, protease, lipase, and it's also going to eventually allow for CCK or cholecystokinin to increase bile secretion from the gallbladder. So that's a really good summary of all those important steps as food passes through the GI tract. All right, any questions so far before we get into large intestines? Cool. So large intestines, one of the major functions of the large intestines is going to be to absorb fluids, to absorb water, right? Feces is going to be made up of about like 70 to 75% water. You want to try to reabsorb as much of that water as possible. There's going to be a couple different regions in the large intestine. So first, let's go from the small intestine. So the last portion of the small intestine is the ileum. And then you have the ileocecal junction. So the ileocecal junction, you're going to have the ileocecal valve. Okay, that valve opens up when chyme is ready to enter into the large intestine, at which point it turns into fecal matter. Then you're going to have the cecum. That's going to be the more proximal region of the large intestine. At the cecum, you're also going to find the appendix. Okay, the appendix is going to be a part of the cecum. The appendix, of course, is a vestigial organ. It's not necessary. In fact, in humans, it causes more problems than anything else, right? You get appendicitis. That's a surgical emergency. You have to go in there and actually surgically remove the appendix. And you can live a normal life without an appendix. You don't need to have it whatsoever. We're going to talk about that in more detail later. Then cecum, then you have the ascending colon. Then as you cross over here, you're going to have the hepatic flexure. So that's where the ascending colon turns into the transverse colon. Then you're going to get to the splenic flexure at the left part of the, upper left quadrant. Then you're going to turn into the descending colon. And then as it makes its way down, it turns into the sigmoid colon because it's shaped like an S. And then from the sigmoid colon, you go down into the rectum, and that's where solid waste can be evacuated from the body. So effectively, what's going on in the large intestine, you do have a lot of mucus production. The mucus production basically just allows for movement of those solid wastes. But also keep in mind, you get mucus production, but you also have water reabsorption. So you want to try to reabsorb as much of the water as possible. We'll talk about why that's important in a second. So in terms of the GI tract, this is pretty amazing in terms of like how much fluids are secreted throughout the GI. 9 liters of fluids are going to be secreted by the GI tract to allow for mixing up of chyme, allowing for absorption of nutrients. So that's a lot of fluids per day. So you want to be able to reabsorb all those fluids, right? Otherwise, you become dehydrated very rapidly. If you do not absorb that water, that's going to result in diarrhea, right? So the less water you reabsorb, the more prone you are to getting diarrhea. If you absorb too much water or if you're dehydrated, that's going to result in constipation. So I'll show you the Bristol stools chart on those different aspects in a moment here. Remember, in the small intestines, you get over 90% absorption of nutrients. In the large intestines, you also get some absorption as well. So it's like roughly 10%. 90% small intestine, 10% large intestine. You do get reabsorption of bile salts, but most importantly, vitamins are going to be not only synthesized within the large intestines with the help of our normal microbiota. We're going to talk about the importance of E. coli, for example. But you also get the absorption of other types of waste as well. So we're going to talk about the role that bilirubin and urobilinogens play. But bilirubin and urobilinogens are going to be excreted by the urine. And then you can also get a little bit of urobilinogens being excreted in solid waste as well. We'll talk about those in a second. But first, let's talk about the bacteria that you find within your large intestines. You have lots of bacteria within your large intestines. A lot of those are going to fall into the category of Enterobacteriaceae. E. coli is going to be one member of that group of bacteria. E. coli, of course, can be pathogenic, right? So E. coli can result in food poisoning. It's also going to be the number one cause of UTIs. There's various bacteria that cause UTIs, some of which are like Proteus mirabilis, Pseudomonas aeruginosa, Serratia, Marsensis. All those different bacteria can cause UTIs, but the most common one is going to be E. coli. Speaking of UTIs, most common in females, more so than males. That's just because females' urethra is a little bit shorter, males' urethra is a little bit longer, and so just because of the length of the urethra, women are a little bit more prone to getting E. coli in terms of UTIs. Other people that are more prone to getting UTIs as well are going to be older patients. So older patients, especially if they are incontinent, right? They're not able to control their bowels. They'll sometimes be stewing in their own waste, and because of that, E. coli and bacteria start entering into the urethra, so that can result in UTIs. Side note for any of you guys going into geriatrics, if you have an old patient, especially an old patient that's kind of bedridden, maybe they're wearing adult diapers and things like that. If they get altered mental status, one thing that you need to rule out is UTI. Altered mental status is a very common symptom of a urinary tract infection. You also want to rule out stroke and other like cerebral vascular conditions as well. But an easy thing to treat would be UTI. You just give the person antibiotics and they're going to be back to normal. So if you see sudden change in personality, you're thinking urinary tract infection. So feces is going to be made up of 75% water. So you definitely want to reabsorb a lot of that. And this is a startling percent figure. 30% of solid waste is actually made up of dead bacteria. So that's a lot of bacteria within solid waste. But the bacteria is really important because even though E. coli can be pathogenic, E. coli is necessary for you to be able to actually synthesize different types of vitamins. Vitamin K and vitamin B. So your B vitamins are going to be produced or synthesized by the presence of E. coli. So these guys are going to be really important for you. Other things to keep in mind here in terms of like odors, those are going to be due to different types of compounds like ammonium, scatol is going to be one, hydrogen sulfide. And then if things aren't able to be properly digested by you, sometimes they get digested instead by the bacteria. And so things that cannot be digested by us, let me just fast forward so like things like this over here, so beans, these are going to be like undigestible carbohydrates, okay? So bacteria are going to be able to digest these. And so that's why things like legumes, for instance, result in excessive amounts of gas production. It's because the bacteria are basically having a party on the foods that you're not able to actually consume or digest properly. So in terms of those vitamins, so you have vitamin K, vitamin B, right? The B vitamins are going to be vitamin B5 as well as vitamin B7. Vitamin BK, that's going to be really important in terms of your clotting cascade. So vitamin K is going to be really important in allowing the clotting cascade to take place because it helps to synthesize different clotting factors, including prothrombin. Vitamin B5, you don't need to know these in specific. I just included that in there just so you guys know. Just know vitamin K and vitamin B are important, but you don't have to know the exact functions of them. But just, it's fun to kind of keep in mind what they actually do. So steroids are going to be produced through vitamin B5, and then glucose metabolism is going to be taking place with vitamin B7. In terms of color, okay, so like feces has a brownish type color. It could be kind of yellowish in color as well. So those colors are going to be imparted by urobilins and then stercobilins. Okay, so stercobilins in particular are going to be the ones that impart more of a brownish type hue, and then urobilins are going to be imparting more of a yellowish type hue. In terms of urobilins and the way that they can be excreted, urobilins and stercobilins are going to be excreted through solid waste, and then bilirubin is going to be mostly excreted through urine. Okay, so they're both going to be excreted in the urine as well as the solid waste, but urobilins and stercobilins are especially going to be excreted through solid waste. So here's another image of all that, all that looks like. So this is kind of going back to when we did our blood lectures. So blood gets formed within the bone marrows. It gets broken down within the spleen as well as within the liver. So macrophages help to break down some of the different contents of hemoglobin. So you get iron is being recycled, but heme is going to be broken down to different components. So heme gets broken down to biliverdin, which is greenish. That's why if you get a bruise over time, like your bruise will change colors. It will kind of be like purplish, a little bit greenish, and eventually as it's healing, it kind of turns yellow. It's basically undergoing a lot of this whole process where the heme within like that bruise starts converging into biliverdin, bilirubin. So you have different colors associated with each of these different phases of heme breakdown. Okay, so we already talked about the different things that contribute to the odors of solid waste. So let's talk very briefly about the appendix. So know that the appendix is going to be found at the cecum. So that's going to be the most proximal region of the large intestines. It's also referred to as the vermiform appendix. Verm means worm. Okay, so it kind of looks like the shape of a worm. And generally speaking, the appendix is roughly the size of your pinky. So it's pretty small. If the appendix does get inflamed, that's going to result in appendicitis. So we'll talk about that in a second. I included this because I think it's really fascinating. I teach vertebrate zoology as well, so we talk about other animals. Like right now, we're actually dissecting a cat. Cats don't have an appendix. Other animals sometimes do have appendix. So primates will have appendices or appendices, what the plural is. Horses have appendix. Koalas have appendix. So lots of animals that consume vegetation will have an appendix. We also consume vegetation, right? But it's not exactly necessary to break down vegetation for us. And that's why it's kind of a vestigial organ. There's a lot of different bacteria found within the appendix in some of these animals that allows them to break down things like cellulose. Think about chimpanzees, right? Chimpanzees have a really large abdomen. They have an extremely long GI tract. That's because they're spending all day foraging. They're eating leaves all day long. Because there's not really much in terms of nutrients when it comes to foliage because of the high content of cellulose. But in order for them to derive as much nutrient from the things that they eat, they're going to have to break down that cellulose. And so the bacteria that's found within the appendix effectively helps them break down those different components. But more often than not, the appendix, like I said, is going to be more of a problem maker than it is useful. So if you do get appendicitis, generally how appendicitis first presents, you'll get a peri-umbilical pain. Right, that's going to be the first thing that starts happening. It's a really sharp pain. Eventually, it starts migrating down. That pain starts moving down to the right lower quadrant. So if a patient ever complains of right lower quadrant pain, one of the first differential diagnoses you want to think of is acute appendicitis. The other thing that you want to also consider if it's a young female is ectopic pregnancy is another thing that could happen, or Mittelschirp's pain. Mittelschirp's pain comes from German. It means in the middle of the cycle, aka when the person ovulates, when a woman ovulates. That can also cause pain during the process of actual ovulation. And so these are all differentials to think of when you think about right lower quadrant pain. But ectopic pregnancy and appendicitis are both potential surgical emergencies. What's up? As ovarian cyst? Yeah, that's possible too. Yeah. So you had, did you have to get it laparoscopically removed? Really? How long ago was that? 2 years ago? How painful was it? How did it start? Did it start as a peri-umbilical pain? And then you couldn't pee? Oh, geez. That's scary. Oh, another thing, speaking of urination, another thing that you might use as a differential, but it's probably unlikely because you get more flank pain, nephrolithiasis, so kidney stone. As it starts moving down the ureter, you can start getting the migration of that pain from the, as the stone makes its way down the ureter. So that might be another differential, but usually that starts as a flank pain in the back. So anyways, good thing to keep in mind, appendicitis, and also know where it's located. So let's continue on here. Let me go really quick over this because this is not super high yield stuff, and for the interest of time, we got just a few minutes left here. So whenever you eat a large meal, you're going to have the gastroenteric reflex. You're also going to have the gastroileal reflex. Gastroileal, you're thinking ileum, right? Because you have that ileocecal valve. Whenever you eat a large meal, that's going to help propel food further down the GI tract. And so the gastroileal reflex allows food to move, or chyme rather, to move from the small intestines into the large intestines, okay? And then we already talked about peristalsis for segmentation, so I'm going to skip that. And then we already talked about this in terms of like distension of stomach and the duodenum. That's going to basically help to propel solid waste along the large intestines. And then once we get into the sigmoid colon, so this is the sigmoid colon over here, and then sigmoid colon turns into the rectum. Usually the rectum is going to be empty. There's nothing really going to be hanging out in there. Once solid waste starts getting into the sigmoid colon, that's when you start initiating the defecation reflex. So that's what's happening over there. Don't bog yourself down with all the different innervations taking place over here. Just keep in mind that the defecation reflex is mostly going to be an involuntary type process, but there are going to be some voluntary muscles involved. So for instance, the external anal sphincter is going to be skeletal muscle. Those are voluntary muscles. However, the internal muscles are going to be smooth muscle, aka involuntary muscle. So you can control this process, right? Just because you get that reflex taking place doesn't mean you all of a sudden have to like use the restroom right away. The external muscles are going to help to, give you time to run to the restroom and relieve yourself. So that's the whole spiel that I have on the defecation reflex. So let's go ahead and move on. So here's another image of what's going on over there. Incontinence, just keep in mind that's involuntary loss of your reflexes or loss of your voluntary reflexes. You can be urinary incontinent, or you could be fecally incontinent as well. So it can happen to either or. And generally speaking, when we, adults, usually it's going to be like stroke patients that all of a sudden become more incontinent. Women that have had a lot of children, right? So sometimes they might become urinary incontinent just because of like damage to those regions. So that's just something to keep in mind. Bristol stool chart. This image is hilarious. I don't know who drew this, but they deserve a high five. So if you're constipated, that's going to be these ones over here. So the first two types are going to be considered constipation. That means that you're either absorbing way too much water or you're dehydrated. So you're not producing enough secretions to allow solid waste to be able to move through the GI tract. Also, insufficient dietary fibers can result in constipation. People who quit smoking. Tobacco and nicotine are going to be things that stimulate defecation. Whereas if you stop smoking, all of a sudden you might become constipated as a consequence. Opioid use can result in constipation. People who are on pain management, sometimes they have to take laxatives, right? So like Senna is a very common laxative that they have to use, like a stool softener. It's not really a laxative. But if a patient is on like any form of opioids, maybe like post-op or something like that, they'll usually have to take some sort of stool softener. On the other side, you have diarrhea. That means you just have way too much water being not reabsorbed and it's just being released. You can also get that because of like, infections as well. So like E. coli can cause diarrhea. Shigella can cause diarrhea. There's a lot of protozoans like Giardia and Amoeba. Those can all cause diarrhea. Whenever you have increased motility of the large intestine and decreased reabsorption of water, basically that results in diarrhea. And then to finish up here, which of these is going to be a healthy colon on colonoscopy? 2, good. So what's going on over here at number 1? That's colorectal cancer, okay? What's going on over here at 3? Do you guys know what that's called? A what? It's called a polyp. So if you see a polyp like that on colonoscopy, the gastroenterologist can literally just go in there and they can just surgically surgically excise the polyp. Nothing really too crazy here. What the hell is going on with number 4? So that's called FAP, or familial adenomatous polyposis, and that is a severe form of colorectal cancer that happens to young people. If this is probably actually a 20-something-year-old person. Usually with FAP, it happens to an individual at a very early age, and so they get these massive amount of cancerous polyps. And then what they have to do with that, they have to surgically excise the affected areas. So they actually have to go in there and surgically remove portions of their colon. So this is all signs and symptoms of colorectal cancer. You might get blood in the stool. You might get abdominal discomfort. Generally speaking, the treatment is going to be surgery. You can also do chemotherapy and radiation as well. And that's going to be it. Let's go ahead and get into quizzes. And what's up? They can remove, yeah, they'll have to surgically remove the affected areas. They'll reconnect certain areas if they can. However, if they cannot, you'll have to have like an ileostomy bag or a colostomy bag. If you guys ever heard that term colostomy is for the colon. Sometimes people get an ileostomy. So that's the connection of the ileum to the external environment. And you have to use it. Basically, you have to defecate into a bag. So, yeah, not fun. So, ulcerative colitis is inflammation of the colon, the large intestines. Crohn's disease is inflammation of colon, small intestines, stomach, esophagus, mouth. Crohn's disease is from end to end, okay? Whereas ulcerative colitis is only going to be affecting the large intestines. But both of those are going to be considered inflammatory bowel disease. Huh? They can take different types of immunosuppressant drugs that can reduce inflammation. Sometimes the patient might actually have to get surgical resection of the affected areas. So like Crohn's disease, sometimes the patient will actually have to get surgical removal of the affected areas. So yeah, not fun. All right, so for the sake of time, let's go ahead and I'm going to go ahead and start it. We're probably not going to make through all these questions. There's only 3 minutes left, so do the rest of these on your own, whichever ones we can't do today. Good. Most of you guys got that correct. Let's just move on. All the above. Awesome. Let's move on. One more before we dismiss. All right, looks like most of you guys got that correct. So bile is able to help you absorb lipids. All right, so Tuesday, first thing, we're only going to be doing the exam on Tuesday, no lecture. So we're going to do the exam at the beginning of class. Sure, yeah, if any of you don't have classes, we can do the rest of them. The rest of you guys that might need to go to a different class, feel free to take off. So for those of you who need to leave, I'll see you guys on Tuesday. Make sure you watch that video from the review session if you haven't done so already. No, I'm not going to release a review guide this time. Just the review session. Just watch that. You should be good. All right, so for those of you who are sticking around, let's go ahead and do the rest of these. Oh, I'm just not doing well. I'm sorry to hear that. So, that sucks. I'm going to retake it. I'm just really not doing well. Bummer. And my study habits are just really bad. That sucks. So yeah. Retake it. I'm not quitting, but you know. When are you dropping it? You're not going to take the next exam? Oh, hey, good luck with everything, okay? Yeah. So this is the last day for you? Yeah. What's your name again? Allie. All right, well. Right. Hey. Yeah. Yeah, take care. Be well. All right, good. Stercobilins, that's going to be what accounts for the dark color. Presence of E. coli. What are the things that E. coli helps to do? Synthesize which vitamins? K, B. Good, awesome. Iron-rich diet, that has nothing to do with it. As a matter of fact, the more iron you have in your diet, so anybody that's ever taken like iron supplements, that actually makes the stool look a little bit more on the black side. So a little bit different. So just know stercobilins, that's going to be the major thing. What's the thing that makes yellowish color? Urobilins, awesome. Good. Most of you guys got it right. Secretin. Or sorry, yeah, secretin. What does cholecystokinin do? Gallbladder. Okay, so gallbladder. It also helps to open up that the sphincter, right? So the sphincter of Oddi opens up with the release of cholecystokinin. Okay, let's go on to the next one. By the way, a side on secretin. This is something that I just recalled from like my days in med school, like over 10 years ago. Secretin was actually the very first hormone ever discovered. So pretty interesting. So CCK, so cholecystokinin. What's going on with cholecystokinin? It's going to be secreted in the duodenum, right? So when chyme enters the duodenum, that's going to stimulate the secretion of cholecystokinin, which allows for gallbladder contractions. So definitely not the ileum. The ileum is going to be the most distal portion of the small intestine. So that's not where you see CCK released. Last one. So with the ileum, think ileocecal junction. When you think about the ileocecal junction, then you're going to know that's the connection from the small intestine into the cecum of the large intestine. What else do you find in the cecum? The appendix. Good. Awesome. Good job, y'all. Have a great weekend, and I'll see you guys on Tuesday, okay?